I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about LH surges and ovulation dynamics, especially in busy women, because we know that the menstrual cycle is not just a series of events, but it's actually a choreography. It is a dance. We talked about this in the last episode, where the follicular phase sets the stage for the LH surge, which sets the stage for the luteal phase. And there can be many points along the way where maybe things do still happen, but they can definitely be suboptimal. And so again, physiology is not an all or none event. I was taught in my training that ovulation was an all or none event, but through a little deeper dive, through my mentors in fellowship and also a lot of the reading that I've done since then in my clinical experience, I've learned that there's a whole range of how things can present in terms of suboptimal ovulation, LH surges, and the downstream effects of that. So just to start the conversation, who here listening has ever expected their period at a certain point in time on a certain date and it didn't come? And you're checking pregnancy tests, they're negative. The next day comes, no period. The next day comes, no period. You know that your REI is waiting for you to call because that's going to set the stage for your next phase of treatment, but the darn period is not coming and it's making you enraged and mad and confused and frustrated. I have a whole other podcast episode on this when the period doesn't come, because I think that the neural circuitry surrounding this phenomenon, it goes straight to the amygdala, it goes straight to the hippocampus, it goes to all the fear centers. And we truly, it can make us crazy people. I've gone through this myself. And, there's some predictability that we rely on. Well, at least this is working, or at least this is my sign that I can move forward, even if the last treatment didn't work. But when that doesn't happen, especially in the face of negative pregnancy tests, it can be truly, it can cause people to go crazy. And I don't say that lightly. It truly is one of those things where maybe on paper it doesn't make sense, but the emotional weight of it is really important to call out. Okay. So what are a few situations in which LH surges can be not optimal? One of them is stress. And why is this? From a biological perspective, we know that during stressful times, it is not good for us to reproduce. This is biological, and this has happened for millennia, right? So if we are living in a famine, or if we are we're being hunted, right, by a predator, it is not good for us to reproduce during those times. It's very expensive to be pregnant. It's very, energetically expensive to be breastfeeding. And it's also vulnerable to be taking care of a newborn. And so all those things make it such that biologically there was a survival advantage to the people who did not have an effective LH surge when there are times of stress, and that could resume when that stressful insult or situation was released. And so interestingly, people might say, okay, well, I was studying for my boards and for some reason my period didn't come that month, or maybe something super stressful in your life happens, like a parent dies, or you have a move across the country, and that tends to throw things off. We see this all the time. And, I just want to call out that this is a biological response that is actually fairly protective for our species. But when we are trying to move things forward on the fertility journey, it can be really, really stressful. And so that's one thing that can throw things off. And, as a reminder, we talked a little bit about reproductive physiology, menstrual cycle physiology in the last episode, but there's this whole region of neurons in the arcuate nucleus in the hypothalamus. And I'm grateful that the lab that my mentor in fellowship shared lab space with, Sue Mentor, she dedicated her life to studying this population of KNDY. They call them candy neurons, in the hypothalamic arcuate nucleus. And they function as the master pulse generator for the GnRH and LH release, which obviously controls mammalian reproduction. And so those neurons, they can be differentially affected by different inputs, different blocking signals, different environments. And it's really, really fascinating research if you want to do a deeper dive into it. But the point is that stress is one of those blockers where when we are stressed, it shuts down the typical negative feedback to positive feedback switch from the estrogen on that pulse generator. And then what happens is that doesn't happen, or maybe it happens, but it's a very weak signal. And we don't ovulate, or, or maybe even that follicular phase is drawn out to the point where maybe we ovulate later once that stressful stimulus is removed. And then the cycle ends up being a lot longer than we would have expected. And so stress is one of the main drivers for an incomplete or a suboptimal or even absent LH surge. Age is also really important here. We've looked at follicular dynamics of older women, and older women do seem to have a less than optimal LH surge at times. And so, we've heard of like perimenopausal women who have these like luteal long, like out of phase, times when they have abnormal uterine bleeding. We also can have these like very prolonged follicular phases as well. But, it's not just like a light switch happens, right? We've talked about this. It's not like all of a sudden you're 25 and then you're 45 or 50 and there's that sort of change that happens in the 40s. We know that the reproductive changes that can affect fertility happen 10 to 15 years before the final menstrual period. And so there can be these subtle changes over time that happen for women, especially in the mid to late 30s. But if your timeline is shifted, it can happen even earlier than that, where you can have an LH surge, but maybe it's not optimal. And that can really mess things up as well. And, that sets the stage for a poor corpus luteum, worse luteal phase hormones like estradiol and progesterone. And progesterone, we know, is the hormone that sustains an early pregnancy. And so if that is not optimal, then that's partly where we might see some, losses because of luteal phase dysfunction, or even on pregnancy if the situation is bad enough. So again, we never know exactly where things are breaking down, but when we see patterns, like for instance, if you're tracking your LH kits and you have a surge and, you're having a luteal phase that's less than 10 days, that's definitely a marker. If you're tracking your LH kits and you never quite get a dark line, you're wondering what that's about, it's really hard to interpret or hard to read, or maybe they're positive some days and negative some days, and it's not really a clear negative to positive that you can track. Those are signs that maybe your luteal, your LH surge and your LH function may not be hitting the threshold where it needs to be for a successful outcome. So age is really important here. Carrying extra weight can also affect these things. So, there's a lot of data about getting women to be ovulatory, like metformin's a classic example, where people gave women metformin and said, oh, well, now people are having regular cycles again, but the live birth rate didn't pan out. It's like, well, people are having regular cycles, but it's not improving their pregnancy or live birth rates. Why is that? And my theory is that this is largely in women who carry extra weight, and it's correcting some of the problem, but not all the problem. And that maybe we're getting people to ovulate, but all the dynamics of the menstrual cycle, specifically the LH surge, may not be optimal for those people. Again, I can't prove it, but I do think that just because somebody's having LH surge and having regular cycles does not necessarily mean that that's going to convert into a positive outcome ultimately. And we all know that the weight creep is real during the fertility journey, right? We might have started at a certain weight, and then, both combination due to being told not to exercise the way we used to. And so we might be eating the same, but not exercising as much. And we know that progesterone can make people hungrier, especially if you're taking a lot of progesterone. That can certainly affect things too. And let's be real, like the emotional stress, sometimes we can stress eat, and that can put on extra weight as well. And so it's not uncommon to gain 20, 30, 40 pounds during the fertility journey, and all of a sudden say, like, where did this weight come on? Especially if it's been coming on gradually over a couple of years, and then really have to work to lose that if we want to get back to, our pre-fertility journey BMI. And so just thinking about the fact that carrying extra weight does affect these things. And if that is pertinent to you, talking with your doctor about like a brief pause, maybe going on a GLP, or really investing in like lifestyle, as you're undergoing the fertility treatments as well. There's different ways to address it, but especially if you're trying to conceive outside of IVF, this can be a really important way to restore a more optimal menstrual cycle. And the fourth thing I will say about dysfunctional luteal phases, especially in busy women, is the same thing we talked about before, is hypothalamic amenorrhea. And, what I find, again, physiology is a lot more complex than we learned in medical school. It's not like somebody necessarily has hypothalamic amenorrhea or HA or not. A lot of people live in this, like, especially a lot of my female physician patients, like this, PCOS spectrum, but kind of HA spectrum as well. And so there's actually data that people can swing back and forth depending on factors like life stress and BMI. Even a few pounds difference can make a difference in this. where somebody one day might have like a PCO phenotype with a high AMH, high antral follicle count, maybe high LH levels. And then a couple months later, their cycles are still absent, but it's more like, low FSH, low LH, low estradiol at the start of the cycle. And I've seen this, manifest a bunch of different ways. I've seen it manifest where maybe somebody had a really tricky LH surge in the middle. Like there's maybe like the kind of a weak positive, but not a full positive. Again, these tests are not meant to be qualitatively interpreted really, but in terms of like being like, well, my line was barely positive, but it was better than the day before, those sorts of things. Or maybe somebody has like, a negative test one day and then a positive test the other day, and it goes back to negative very quickly, like again, inconsistently hard to interpret. And also short luteal phases. Again, if you are having a short luteal phase, definitely under 10 days, but even under 12 days can signify like a short luteal phase. You have to wonder if that LH surge is happening in the appropriate way where there's that, choreographed spike. Some people even have a bimodal LH surge, which isn't necessarily wrong. It's just a variation. But it just shows, again, physiology it can be diverse and not just like having people in categories. But if the luteal phase is short, that suggests that when that LH happens, there probably is an ovulation event, but those hormones don't last as long. Maybe it's just a crummier corpus luteum, which can happen with luteal phase with this sort of dysfunction. It can happen with age. It can happen with egg quality and other things. But if the luteal phase is short, you have to wonder like what's going on. And so some people with HA truly just like never have a period. That was like me during college and early medical school when I was running so many marathons. Like my body just shut down. That makes total sense. But like I said, there is this sort of incomplete HA PCO spectrum thing that can happen. You can have HA without PCO, but I see a lot of the hybrid situations where maybe you get your estradiol and it's like, 20 and your LH is 2 and your FSH is 3. That would be a very classic example of somebody who has this. But there's something called functional HA, which is basically where, you can't always tell it from the labs, where the situation is one of relative low estrogen because somebody's not ovulating and they have, normal FSH, normal LH, but the estradiol just stays low. It can be really hard to tell that from PCO. Sometimes in PCO, the LH is higher than the FSH. Like we learned about, 2 times was part of the diagnostic criteria. It's not anymore. That's why one reason I like to check an LH with my baseline labs, because I know not everybody does, but that gives me a window into like, could this be HA? Could this be PCO? Like, what are we really dealing with here? But I do think that there's a lot of female physicians, especially because of the, many people do have a lean BMI, and not everybody, but many people do. And that really can affect how the LH surge is, how the luteal phase is, and can be part of the story. So, when we combine being a high achieving woman, maybe a female physician, a stressful career, altered sleep schedules, altered night shifts, maybe you're a trial attorney and you have a big case coming up and all of a sudden there's all these deadlines and, it's high stakes because you really want to do right by your client. Like there's all these situations that can come up. But what I've learned is that fertility is not just one giant thing. Usually it's like a bunch of vectors, like a bunch of different littler things. And if the vectors are all lining up in like a bad way, that can keep people subfertile. And sometimes some gentle life optimization, stress optimization, I know we all have to work, but sometimes we hold ourselves to such standards where we may not need to work quite as hard as we are. Or maybe there's small ways that we could lighten the schedule without it having like a huge impact long term. And so just looking at it, is there any space in my days? If I had a kid already with this schedule, welcome that sort of lifestyle. I think, those are hard questions to ask, and it can be hard to change our habits, especially when we live in a society that rewards us for productivity and all these things. But when we can understand that our, optimal menstrual physiology may be related to our stress levels and how we fill our days and how many things we say yes to and all of that, I think we can make a pretty solid argument for optimizing natural fertility as best we can and taming some of the busyness, having a little space in our days, even giving ourselves transition time. Maybe it's that you like take 15 minutes before you walk inside your house once you get home and you put away the stress of the day and you enter in. Or maybe it's that you decide that you're going to start meditating in the morning or walking your dog a little bit longer in the morning. Like whatever it is, we are really unkind to ourselves. And like for me personally, when I stopped running marathons, that's when my LH surges happened again. And I wasn't necessarily connecting the two. I was like, oh, this is just what happens. I need to be running marathons. But if you question the assumptions of the decisions that we're making, right, sometimes there's some room for some more optimal physiology. So I hope this was helpful. Happy to answer any more questions you have about LH surges and stress and busyness. But again, it's a hopeful message because I do think that there's a lot that we can do. And when people have made even modest lifestyle changes, I've even seen like letrozole, if there's enough LH on board in the context of even some mild ovulatory dysfunction, I've even seen letrozole, overcome that in people who were previously diagnosed with really low LH and HA. So anyway, you know how much I love you. Can't wait to answer more of your sciencey questions. Until the next time. Bye.